Today's lecture is basically on total hip arthroplasty. I'm sure every orthopedic surgeon, particularly general orthopedic surgeons, also would love to do this technique, this surgery, because it's a very, very common surgery now, and it it's a very gratifying surgery if you really ask about it, because it gives excellent mobility to the patient. So it's an excellent treatment option for people with late stage degenerative hip disease and one of the most successful and common surgical procedures. Why we need to do it is basically pain, stiffness, and disability. I'm not going to talk about the indications because we are talking only about the technique. And so these are the three main important symptoms or things for which we need to do this surgery. So usually whenever there is cartilage degeneration, which leads to pain, stiffness, and disability, whether it is because of the osteoarthritis, whether it is because of the AVN, or any other, ultimately there is degradation of the cartilage, degradation of the joint surfaces, which leads to pain, stiffness, and disability. And hip being a very mobile, hip being a very mobile joint, the symptoms are very pronounced in such cases. So benefits are there is marked reduction in the pain. There is improvement in sleep. Generally, as we all know, night pains, I think we discussed in last few classes that night cries, night pains, all these are because there is severe pain, particularly during the night when the muscles relax and you start getting pain. So improve sleep. Most people regain range of motion, physical ability. Even unlike knee, which is also a very gratifying surgery, hip range motion gained after an orthoplasty is much more gratifying. So ultimately, it leads to excellent quality of life once you do a total hip replacement. That's why it's a very gratifying surgery. So straight away, we're going to how do we do it. First and most important is, of course, finding the right indication and doing it at the right time. So when that is a different class, so now we will talk about that later. So how do you do it? Basically templating. I think last time Dr. Yadav only talked about templating and all that. But these days we don't get templates from the companies, but I feel for a beginner, for somebody who is not doing it regularly, it is very important to template these hips before you really embark on the surgery. So measure the femoral head diameter. It is very important that you know what you're actually planning to get. So suppose you have a 52 millimeter cup size, you should at least be able to have that in mind. So you have 48, 52, 54. So you should be having the diameter prior, at least some knowledge. So cup, which is little way up and down around that diameter, which you have already done by templating, will be more, you will be at least, because otherwise I have seen, particularly in femur, you can many times put an undersized femur, which on the table you feel because you're worried, but later post-operatively you see there's a lot of variance in the size. So it is very important you measure the diameter beforehand so that at least you have a fair idea of what you're going to do ultimately use. So 4 to 6 centimeters larger than the templating is a routine thing which you can expect. So medialize into the inner table of the acetabulum. So once you're doing templating, you should medialize it. You should take it as close to the teardrop as possible. So that is what gives you actual size. Many times because of under reeving, we put a very proud cup, which looks holding well on the table, but then once you see the X-ray, you feel that it is lateralized. So it is very important. Templating should be done prior, and I think you should make it a habit. Honestly, even I don't do it regularly, but all I can advise you is that you should try to do it. Force your company fellow to get the templates and try to do it regularly, at least initially. Particularly in a place like nursing homes and smaller hospitals where you don't have the full assembly companies also don't try to be very compliant by getting all the implants. They try to save their own inventory. and suddenly you are stuck in the nursing home. So you should always have a template so that you are aware that what size you are going to take. And then inferior margin of the cup should be, so other important things, you should identify teardrop. You should see every time you see a pelvis x-ray, hip x-ray, try to notice the teardrop. So that gives you a fair three-dimensional view that ultimately what you're dealing with. Teardrop is the junction of the pubic ramus, ischium, and ilium. So that is a U-shaped, which you can see very easily on any X-ray. So you should always be aware that your cup should touch the teardrop. So it should be nearer to the teardrop. So otherwise, you are lateralizing. Although your rim hold may be good, but ultimately you have a base which is not touching. So chances of loosening are very high. So always try to have a full three-dimensional hold of the cup. So if you go as close to the teardrop, that is as that is an accepted mode. So then the cup. So template, you should position it around 45 degrees to the vertical. So you should have a three-dimensional understanding. So if you draw a line between the inferior margins of the ischial, ischial tuberosity, so if around that, if you keep a line parallel to that, your cup or template should be around 45 degrees to the vertical or the transverse plane. So that again gives you how much cup rim is outside the vestibular lip, that you can understand in preoperative X-ray templating. And then you should mark your template, vestibular shell template, mark the femoral head center using template hole as a guide. You have many times small holes, or there is a point marked on the cup template, shell template. So that should center on the femoral femoral head center. So that gives you a fair idea what is going to be the position. Then again, X-ray analysis is very important preoperatively. Many people, particularly people who just go and operate for somebody else, it's very difficult if you are not understood the whole. So it is very important that you understand. So even if you're operating for somebody else, you should go and see the X-rays before you really start the incision. So you have the full understanding of the whole anatomy of the cup and the femoral head. So see that inferior pelvis, lesser trochanterian line up if there is any discrepancy in the length, so that ischial tuberosity line is parallel, is horizontal. This is the central line is not broken, is unbroken, and center of rotation of the head should be marked as I told you on the template. So position stem template properly at the determined center of the rotation. This based on 4 goals. So basically, you have to restore the neck length. You have to maintain, establish the femoral head offset. We'll talk about that in the next 2 slides. So achieve a neutral axis alignment. These are the 4 important goals which you have to achieve in whenever you are doing a total hip replacement. So achieve a good fit. So metaphysis, all these stems are based on a good fit in the metaphysis. You cannot have a good fit in distally while your proximal fit is poor. So that will lead to failures later. You might have implant breakage, or you might have loosening if you have used an uncemented hip. So good metaphyseal fill is very important. So that is how you do your reaming properly. And the surgeon is using a press fit or cemented stem, depends again on the proximal metaphyseal fit. So as I told you, operating surgeon has 4 important goals. So one is restore the neck length. This is how you see the neck length. So you should do, even on preoperative templating, you can see that what is, and even when you have opened up the thing, you should take these measurements. Try to make a habit of taking these measurements. So from the tip of the line on the lesser trochanter, or a line where your actual cut is going to be, you can start see the length of the center of the rotation, and see the neck length. So this you have to restore. The second is maintain the femoral head offset. Offset is the deviation from the central axis to the center of the femoral head. How much different hips have different offsets. And so generally we take 132 or 127 degree offsets conventionally. So that is again you have to measure. Many times chances of dislocation, chances of subluxation increase if you have not understood the offset very properly. So that you have to maintain again. So draw a line on the center of the femoral head and a line in the axis of the femur, measure the distance. That is, or you can, when you are doing that. You can see from the tip of the femoral stem and then trochanteric tip. You mark these points so that you can measure and compare them preoperatively and postoperatively. Achieve neutral axial alignment. The center, as I told you, the axis of the stem should be in the center of the axis of the femur. So you have to achieve neutral axial alignment of the femoral stem. So it should be bang in the center. Earlier, we used to have sort of a varus stem would prefer, but now with these metaphysical fit prosthesis, it is very important that your fit should be in the center. So don't deviate. That means either your stem is loose or your tip may touch the cortex, which causes pain in the thigh later to the patient. So always try to keep the tip of the stem centralized. So there, besides being a good metaphysical fit, your tip should be in the center of the sort of stabilized in the center of the medullary canal. So that gives you a good weight bearing, plus that there are less chances of loosening in such cases. So achieve the next is again achieve a good metaphysical fill with the implant. So as I told you, whether you do it with a cement or whether you do an uncemented, the metaphysical portion of the femoral stem should be well fitting in the metaphysis of the femoral shaft. So there should not be any discrepancy. Otherwise, what will happen? It will start loosening, or there will be stress failure there, because you have a well holding distal stem tip, while a very loose proximal the stem part of the stem. So ultimately, there is a stress riser at the junction of the metaphysis and the shaft of the stem. So there might be breakage. We see lots of Indian implants breaking there because the metal used is not of so good quality. And if you have not done a good metaphysical fit or even a distal femoral fit, they might fail in over a period of time. I can show you probably a few slides if I have time. So good metaphysical fit. So you should do reaming till you get a good fit. That I will talk in the technique how to do that. So preparation. So before you embark on total hip replacement, for that matter, any arthroplasty, you should see to it that there is a clean air operating room. Don't try to do this surgery anywhere and everywhere. You might get 10 cases which are very clean and without infection, but there will be one case which will harass you for the rest of your life, because infection in arthroplasty is a disaster, and try to avoid such situations as much as possible. So induction room and wash up close to the OR. So don't travel from one end of the OT to the other end if you're trying to wash up for this. And many hospitals have separate induction rooms. So try to be, again, there is a lot of contamination. So these surgeries are very air contamination sensitive surgeries. So it is very important that you maintain the OT room, operating rooms very meticulously with lowest amount of contamination. So temperature also should be well below the room temperature. It should be around 18 to 22 degrees, so that chances of contamination are very less. So standard, we need a standard operating table with arm supports. Surgeon is responsible for proper positioning, particularly for younger ones. In fact, I'm also liable to not do that off late, because now probably because of the age, I let my juniors position the table. But for a younger surgeon, it is very important he positions it himself, because here, if you have not positioned it properly perpendicular to the floor or to the table, your version of the cup may change. So it's very important that before the patient is draped, the surgeon should at least have a look at the position of the table. He should see to it that it is well centralized, it is well perpendicular, the whole pelvis is perpendicular, and it is well fixed. So it should not be loose by the end of the surgery, because you have to do a lot of hammering, a lot of movement of the limbs. The whole pelvis may sag, so your version may change. So in fact, very recently I had such problem. We put a more antiverted cup because of, probably, I don't know why, because we do this surgery so regularly. Yet there are days when if you have not taken good care, you might end up doing a poor positioning of the cup or the femoral stem. So position your patients very well, and it is a responsibility of the surgeon to see to it that it is well positioned. As you can see in this, we have a pillow behind. There are tables where you have all the adjacent these posts available. So they see to it that it is well fixed. So even if you are using a pillow, see to it that it is well fixed and it is not moving, sagging at the, or even at the end of 1 hour of surgery, the whole pelvis may sag backwards or forward. So you lose your version. So it is very important that you ensure that the patient is well fixed to the table and it is stable, and it will last, the stability will last for almost 2 hours of your surgery. So perfect lateral decubitus position, patient towards edge of the table, get it towards the surgeon on the dorsal side. Don't keep it on the center of the table, try to move it towards the edge of the table. Contralateral knee is flexed 90 degrees and hip is 60 degrees secure to operation table. So that it is, and it should be well cushioned. So because if you have two, there should not be popliteal nerve palsy of the opposite hip, opposite leg, if you have not padded that well and nicely. Ensure safety of the down leg, safety of the brachial plexus, because generally the one arm may be hyperextended, so you might have brachial plexus injury before that. So see to it that all these are positioned very well. So final examination for leg length discrepancies. You can even measure the leg length, at least try to achieve the same length. So at the end of the surgery, you are trying to compare it with the opposite hip. So have the feel of that how does your femoral length compare to the opposite hip, so that where exactly is the knee, so that here you can check it. Later, once it is draped, you may not be able to feel that. So if you have done that preoperatively, you will probably able to better understand the length. So ankle and ankle, malleolus and malleolus matching, knee and patella matching, you should do it before draping, so then you can understand how you do it post while in the drapes after the implant setting. So ensure hip flexion and reduction. Many times there's a big post or a pillow in the front and on the abdominal side. So when you have to check flexion after the implant, the flexion is not complete or your adduction is not possible. So you will not be able to see the coverage or the version of the implants if you are not able to do it on table. So see to it that you are able to flex the hip very nicely before you drape. So scrubbing and draping, scrub from the nipple line to the toes. You can first scrub the foot and ask your assistant who is draped to hold the foot after you isolate the perineum. Scrubbed assistant should hold the foot, and then you do the main operating area. So disposable impervious drains, drapes are state of art. You should use them. If you don't have available, at least use a lot of plastic sheets before you put the cloth drapes on the page. Otherwise, you will end up, because you need to do a lot of wash, and it's a long surgery which bleeds a lot. So you might be, the whole drapes may be soaked. So see to it that you have impervious drapes. If you don't have those available, at least use adequate plastic sheets. We can use almost 5 to 6 plastic sheets if we want to drape for the hip before we put the cloth drape. So there is one on the lower end of the table, one on the upper end, one on the one side. So everything is plastically sealed with the plastic sheets before we put the cloth drape if you don't have it. But if you have good straight these drapes available, then you can use them. So use Steri-Drape. Many people try to use stockinites in the foot and then don't. But then even on the stockinette, you should put a Steri-Drape so that it is impervious. It doesn't, because your foot may not be so well scrubbed. So at least it is covered and adequately. Incision, we use a conventional posterior approach, Cocker-Langenberg type of approach, which is if you have kept hip at 45-degree flexion, it is more or less a straight line. So you mark the trochanter and then draw around 6 to 8 centimeters distal to the vastus lateralis ridge and 8 to 10 centimeters proximal. Initially, you should give good adequate incisions. Many people have the experience and knowledge to do it in smaller incisions. But I think for younger surgeons, even if you are doing a bipolar, you should take an adequate incision so that you retract the tissues very nicely, and then you are able to expose the hip very nicely. So incision is given. So cut the fascia in the same line, detach gluteus maximus tendon. You can give an Charnley retractors can be centered to the trochanteric ridge. Identify the key muscle, which is the piriformis. Piriformis is also known as the gateway to the hip. So once you identify the tendon, what I do initially, I keep the piriformis tendon there intact and put a spike above the piriformis, or even take piriformis with the gluteus medius muscle, so that it is very important that you protect the gluteus medius muscle, because that is attached to trochanter. Many patients whose hip has not been ankylosed, or was they might have very thinned out abductors. So you need to, that is the most important key point, where first identify the abductor. So piriformis is the identification mark there. So once you see the piriformis, you can retract the whole piriformis up before you cut it later, so that you expose the hip properly. The other thing is locate the sciatic nerve. At least even if you don't see it.
दूध रखो इधर ही, दूध रखो इधर ही, रखो दूध नीचे, रखो दूध नीचे। नहीं नहीं नहीं, आप दूध रखो नीचे, मैं बोलूंगी क्या करना है, रखो पहले दूध नीचे।
Galaxy M30, can you please mute yourself? Can the participants please mute themselves?
हाँ।
So other important point is I identify the sciatic nerve. Sciatic nerve is going right across this hip. So you may not like to see it, but at least feel it. You can feel it, and once you are oriented with that position, because as you go down towards the gluteus maximus insertion, sciatic nerve is almost touching the insertion. So you might many times hurt it there, if not at the proximal part. So identify that, feel its course. Once you know that, then you are aware that it is always sitting there. Then I use mop a lot, so I scrape sort of all the soft tissues from the rotator, so they'll look very nicely in front of you, going across the wound from transversely. So once you do that, you, before you cut them, actually identify them very nicely. So with the mop, sort of scrape them, the tissues from it, so that you can identify all the three rotators. Plus, then you can cut the piriformis. Once you have identified the rotators, you can put a spike below the abductors, and then retract the whole thing up, and also try to go distally towards the quadratus femoris, and see, you can put a spike there, 90-degree spike there, so that the whole 180 degrees of the hip joint is right in front of you, with three rotators going across in the horizontal manner. So that's as I said, blunt dissection with the mop. You erase the whole soft tissues and expose the rotators. Then incise radially and reflect posteriorly. You can start from the vestibular, this trochanteric ridge, and then go with the cautery, small blunt incision, blunt cuts. You expose the rotators, you cut the rotators. Don't try to directly go to the, what I would prefer is, don't go directly to the bone. You go on reflecting the rotators, so that you can see glistening capsule, sort of, it is like a sac around the neck and head. So don't try to cut the capsule. Many people prefer to go right up to the bone and cut the capsule in line with the rotators, but I prefer to see the root capsule, because then you can do a good dissection all around the neck, and see, you trace the capsule inferior to the neck also. There you can put a spike, and there, so then you have a full balloon of capsule looking at you, with rotators retracted, and a spike going above the capsule, superiorly on the capsule again. So once that is done, you can even reflect with the stili scissor towards the ischial tuberosity, and so that full circumferential, almost 180-degree or maybe more, of capsule and neck is exposed without cutting the capsule. Once that is done, then you cut the, you can put a retractor, pin retractor on the top. I prefer to put the pin later, once I've identified the transverse ligament. Before that, I cut the capsule in a T-shaped manner. I hold the capsule lips, and then trace the inner side of the capsule, so that you identify the rim. So and then with the cautery, sort of demarcate the whole rim, almost full from the 10 o'clock towards the 6 o'clock or 7 o'clock position, so that the whole acetabular rim is exposed. Once that is done, you can identify the transverse ligament inferiorly. So almost diagonally opposite to that, you with the periosteum you erase the gluteus muscle and the anterior, the straight head of the rectus, and there you can put your pin. So pin is almost diagonal to your transverse ligament inferiorly. So that gives a good orientation later once you are planning a version of the, once you are checking the version of the cup. So amputate the femoral head, divide tight synovial or capsular tissues. So as I told you, you hold the capsular lips and then go along the inside of the capsule and sort of demarcate the whole acetabulum all along. In fact, initially you can do it on the anterior rim so that you can put your retractor there, so that the whole femoral shaft along with metaphysis is retracted. So you don't need to do anteriorly complete release. You just in the around 3 o'clock, you just with the cautery sort of demarcate it, and then you can either with a small periosteum, you can make an entry there so that your spike, this can go inside, and you can retract the whole femoral shaft anteriorly. So you have to release the inferiorly also. Mark the neck cut with the cautery. As I told you, either you have a template which is positioned well positioned along the axis of the femur, or you can, if you are not able to put it inside nicely, you may just draw a line along the axis of the femur and then make a 45-degree cut with a around a one finger breadth away from the lesser trochanter. So leave a longer neck initially. You may not cut it exactly the way you wanted it, but you can leave it longer initially. So see to it that your limb is held exactly perpendicular to the floor. So your leg is almost vertically standing, held by your assistant, so that the neck is almost parallel to the floor, so that your neck cut is not antiverted. So even if it is while cutting, you can reshape it so that the two edges of the neck are equally cut on the anterior as well as posterior. Otherwise, you might have an antiverted neck or a retroverted neck cut, particularly in cemented stems. That is an important issue. So avoid damage to the hair when you're doing a neck cut. Many people use the saw. So while the saw is oscillating, you might knock off the trochanteric tip. So try to see to it that your saw is not impinging on the trochanteric tip, so that otherwise you'll have either an abductor cut or a GT cut there. So what I do is I take a vertical cut along the parallel to the GT at the near the entry point of the trochanteric, this neck, and then cut the oblique cut, so that later with an osteotome you can complete the cut. So relax the anterior capsule by internally rotating and flexing. Pierce the capsule with Homans, as I told you. Make a small release their anterior capsule at around 3 o'clock position and put your Homans there. Use anterior wall retractor to retract the femur. Avoid inserting tip distal to the mid portion. So don't take it distally towards the inferior like tal on anterior side, because your femoral artery is very close there. So keep it around, as I told you, at 3 o'clock or maybe a little higher, so that once you are retracting the anterior on the anterior wall. And then identify the tal, you can feel it with your finger in virgin hips. And then you can position your retractor below the tal, so that it goes, you can with a cautery make a release there and put the retractor there, so that you can see tal while you are reaming. So this way you expose the whole entire acetabular rim. Expose the then Then you see the space between the two articular surfaces, which are like the cotyledons, like see the non-articular portion of the acetabular. That is the floor of your acetabular. So that is the most important point once you start the reaming. So see the medial wall, that is the non-articular part of the acetabular. So if that you have an hang of that, you have seen that, that is your end of your reaming. So remove the overhanging medial and inferior osteophytes, check the walls for any defects or cysts, ream at an angle of 45 degrees. You can do an initial, the smallest reamer you have, you can do it in a vertical position of the 90 degrees to the floor. So that the edges of the articular surfaces are flattened. So that gives you the idea of the floor. So you don't go beyond medial to that floor. If that is not, if there is no protrusio, or if there is a usual hip where the articular surfaces are still intact. So that is you can do initial reaming with at 90 degrees. Then slowly you start reaming in the direction that is the 45 degrees to the horizontal. So all the reamers should be in the same direction. Otherwise, you will end up doing a very reaming which is not concentric and not well centralized. So accommodate 15-20 degrees of. So last few reamers you should keep in 15-20 in the right anteversion. So don't try to think of anteversion only while putting the cup. So your even reamer should be in the same version, at least the last 2-3 reamers. So always keep on checking the position of the reamer and position angle of the reamer, so that you are reaming in the right direction. And always keep checking with your mops or with your, so that you're not going to breach the medial wall. So as I told you, the floor, which you can mark with a cautery or something, that should be always in your mind while you are going towards the final reaming. You have also jigs to see that you are in the right anteversion. Many companies, almost all the companies do provide that. It's only that you have to ask for that. So you can check it once or twice on the particular reamer, so that you are well aware, you have a three-dimensional orientation of the direction of the reamer which you are doing. So you have to create a cavity large enough for cement and cup, full bony support from ilium, ischium, and pubis. So all the three areas should be well supported, so that it will be a good bone stock on all the sides. Preserve the subchondral bone of the roof. So don't over ream. So if you see a lot of cancellous bone, that means you are over ream. So see hard subchondral bone which is punctate bleeding. That is the end of your reaming. But then there should be concentric widening of the acetabulums. Do not go in only one direction. So do not deepen beyond the level of non-articular, as I told you. And the pulvinar, the non-articular part of the cup, that you have to always keep in mind. You don't go beyond that. That is the floor. If that is very clearly seen, that is the floor. So you may do initially with small reamers, priority reaming, what is called as priority reaming, some areas which are where there is a lot of urination, or where there is, you have to do, that is not getting, the cartilage not getting scraped with the reamer. You may do priority reaming with a smaller reamer in those areas. So then holes for anchorage. In case of cemented cups, we need to do holes for anchorage. So you make small holes in the direction of the ilium, in the direction of the pubis, and in the direction of ischium. These are the anchorage holes where cement gets anchorage in case you are doing a cemented cup. So then you have to look for that is why if you have checked the preoperative x-rays, there may be defects seen or cysts seen, which you should identify. Many times we under ream and then we don't realize that whether we have reached the floor properly. That's why you said you might be a lateralized cup. So identify the defects and do cancellous, whatever scrapings you get from the reamer. You can put these scrapings and punch them into these cavities. First you freshen them and then punch them, so that there are no defects in the acetabular floor and the acetabular wall. So fill these with the graft. If they are very large grafts, you may need it from the head. Otherwise, just the scrapings from the reamer is good enough. So keep the cavity dry by packing with sponge. If you are doing cemented cups, in uncemented, you may just pack it with the mop. There's no need to give a proper wash or clean them. So use trial with the same diameter as the last streamer. The company fellow will tell you the exact size, because different companies have different. Generally, usually it is the same reamer and the same cup size, because they have an incorporated 2 mm or 1 mm uh, uh, incorporated in those cups. So you don't need to undersize or oversize to get a good fit. It's always accounted for. So proper positioning to minimize the potential impingement. So see to it that your cup is well concentric. It is not antiverted, or with the trial you check that. So there is no impingement. So suppose the anterior rim is more proud or posterior rim is more proud, it can impinge on the neck and lead to dislocations in such cases, or even pain sometimes. So avoid excessive vertical orientation. So see to it that many times, if you're not well versed with the procedure, you can take the help of the C-arm, so that the vertical orientation leading to the premature wear of the liner. So don't keep it too vertical or too horizontal. Ideal is 45 degrees, but you can err towards the horizontal side rather than the vertical side. So see to it that you don't have a vertically loaded cup. So that can lead to premature wear and failure of the liner. So recommended cup position, as I told you, 45 degrees. So that is how, as I told you, the pelvic position is very important, that it is well fixed. It doesn't sag while hammering or reaming the cup. So see to it. In fact, you should, before you actually try use the trial, you should see to that your pelvis is vertical and it is not sagging forward and backward. So before you put the final cup, ensure that the orientation is in an acceptable position. So 45 degrees to the horizontal. As I told you, there are jigs available which you can point in the direction of the shoulder and see to it that it is at 45 degrees. Then version around 15 to 20 degrees of version is accepted. Don't go beyond that, because that can lead to chances of anterior posterior dislocation in such cups. So vestibular cup insertion, rehearse cup insertion and position. So trial is very important. Don't bypass this step. Cement putty, if you are using a cemented cup, the putty is pressurized with gloves. You can use the glove filled with mop and then pressurize the cup. Hold it for, don't rush. You have enough time. These present generation cement have a lot of setting time. So at least you should wait 4 to 5 minutes before you start pressurizing the cement. Otherwise, it will be all spilled out and you will not get a good pressurized position. So oscillate this socket holder to deepen. So keep oscillating it. So you are deepening the whole cup so that it sits exactly on the floor. There should be hardly any 1 to 2 millimeter cement space in between. There's no need to have lots blobs of cement there. So for a good cup hold, the cement should be evenly distributed. So keep on oscillating that and deepening that so that you get a good hold. And as you have assessed from the trial cup, the coverage should be same as you have checked with the trial. So bring the handle gradually for final desired position, and steady pressure with pusher. So you can add a pusher there so that the pressure is maintained. Remove excess cement, coining of the cup in rubbery stage of cement. Coining is just tapping the cup handle with your hammer, or even with the hand sometimes. And disengage the cup holder, maintain pressure, avoid clumsy disengagement, avoid excessive pressure, bottom out, avoid unchecked cement outflow anteriorly. So keep a watch on the anterior side, because there should not be unchecked, because there are important structures on that side. So see to it that there is no uncheck, and that is why you need to wait enough, so almost 5 minutes before you really pressurize the cement, otherwise it will all spill out. So place a clean sponge gauze to protect the cup. It's very important while you are cementing that there should be no talking at this stage. So take this step very seriously, because you are in a mess if the cup position is changed or orientation is changed while cement is inside. So see to it the whole OT should be silent and the whole focus should be on everybody. Even your assistant should be noticing you how you are putting your cup, so that there is no loss of position or loss of cement in different directions if you're not taking it very seriously. So for press fit cups, initial reaming with spherical reamer, 4 millimeters smaller than template size, ream up to bleeding subchondral bone in uncemented cups. If dense hard sclerotic bone over reaming by 1 millimeter, avoid potential problems like acetabular fracture, deformation of titanium shell. So don't hammer it unnecessarily. See to it that it is very smoothly going. And there should be good support all along, but don't unnecessarily hammer it. If you're cracking the cup, your cup may lose its hold over a period of time. You may have some unrecognized cracks there, which can lead to failure later, subsequently in the post-operative period. So, and make the seating also difficult. So if your position is not, you have an overflowing anterior wall or overflowing posterior wall, your seating of the insert will be difficult. So the whole goal is that you are in the center of the vestibular cup which you have created with the reaming. So it should be in the center of the original vestibule. It should not be superiorly loaded. It should not be horizontal. It should not be vertical. So it has to be in the center. So ensure that this is a very important step, and a step which is liable to failures if you are not taken care. So anchoring screws, you can, in an uncemented cup, you can use most of the cups provide holes in the superior lateral and anterior lateral area. So you can put 3.3 millimeter drill bit and a 6.5 mm cancellous screw which they provide. It should be well concentric hole. So otherwise the rim of the screw may be abutting out, and which will cause, which will not allow your insert to be positioned properly. So ensure that inside of the metallic cup is clean and without debris. You can give a good wash, clean it with your gauze pieces. And then if you're putting a ceramic liner, you should handle them with care. Don't be clumsy and let them fall. Or they should be, ceramic liners have the tendency to get locked in a very non-concentric position. So it is not like plastic, that they are not so much pliable. So a plastic liner will, if you hammer that, it will sit in position. But your ceramic liner is not well concentric position in a concentric way. It may get a temporary hold, but then it is not sitting properly. Then it will be liable to fail later. So see to it that ceramic liners are handled with care, and see to it that before you finally hammer them into position, that they are sitting properly. Then coming to femoral preparation. So once your cup is done, pack it with the gauze and take out your anterior retractor, expose the femur. You can put a bone skid underneath the neck, or if you're not very comfortable with that, you can just position the leg across the table. See to it that your trochanteric area is jutting out and prominent in the wound. Knee is head at right angle with tibia at right angle to the floor. So for anteversion, you need to ensure the surgeon has to decide whether he wants it at right angle to the floor, or he wants it around 10 to 15 degrees deviated, rotated, so that your version, because don't keep changing so you have the habit of keeping it right angle, keep it, otherwise you'll create mistakes. So one assistant may keep it at right angle, the other assistant may keep it in 10 degree rotated, so that you have a neutral version at the top. So be sure that your assistant knows what you want. Otherwise, you might be on a different frequencies. So you have given, you have expected him to keep in 10 degrees rotation while he has kept in right angles. So your version in the neck will change. So see to it that both of you are in sync, and you know what both of you know what you want. So deliver the neck out of the wound. Remove the overhang of the GT. The neck should be, you should go as medial as possible without reaching the trochanter. Remove the overhang, lateralize the entry point, go as lateral as possible, but don't take out the complete cancellous bone there. Just widen it good enough so that you get a good entry to the axis. As I told you, the reamer should be in the axis of the shaft. Don't deviate it medially or laterally, because then the whole stem will deviate. So see to it, ensure that this step that you are in this center of the medullary canal, so you go a little laterally. Position the chisel in desired anteversion. So don't position the chisel in any position, because then try to keep it also in the anteverted position, the way you want your stem to be. Ream with rotatory reamer to seek and expand the isthmus and medullary cavity. And don't bypass these steps, because if you don't ream with the straight reamer, if you directly ream with the stem reamers, then again you may deviate. So make a good entry point and see to it that your isthmus is wide enough with a straight reamer. Then cavity is enlarged with the appropriate broaches. A minimum of 1.5 to 2 millimeter cement thickness is desirable in case you are using a cemented. So don't over ream, don't completely denude the whole cortex of the cancellous bone. Decide a good fit, and then because the 2 millimeter cement thickness is adequate. Don't have blobs of cement around the trochanter. Many times we see large cement mass near the trochanter. Because you have over ream, you have taken a lot of bone out. So do as much as you need it. Strong cancellous bone is preserved, broaches are inserted in proper anteversion and valgus orientation. So how much do you need to ream? So every time the broach buries deep into the neck of the neck cut, that means you shift to the next reamer. So if it is sinking in, that means you should shift to the next reamer. If it is proud, then you don't go before you go to the next reamer. So don't do these steps very fast. So you just ream with the one reamer, go to the next reamer. So don't do that. See to it that the end of your broach sinks inside the neck, so that you shift to the next reamer. So and here also again, it is important that templating has been done properly, so that you have a fair idea. If you have seen on a template that you need a stem of size 3 or size 4, and here you are just getting a good fit with just size 1, that means there is something wrong. So you need to revisit and see that, otherwise you will under ream or you might end up over reaming. So see to it that you are in sync with your templating. That's why templating is important. I have seen stems which we thought on table are good fit, but on post-op x-rays we found that they are inadequate. They are not well-fitting stems. So these are liable to fail. So then neck length is adjusted until neck length is equal. That is why once you have written on the drapes, what I told you earlier, that how much offset is needed, how much length, how much is needed, a vertical offset as well as the horizontal offset, you need to now check with the trial. So stability checked by telescoping and full range of movement, telescoping more than 2 millimeters or dislocation. If you're doing shuck test or telescoping, it should not be more than 2 millimeters. So that means it is unstable, or you need to go to the next length. So extended offset design, one to be considered. So as I told you, normally we have 132 degrees, but if you need an extended offset, so you might, if your fit is not good, if your is not tight enough, you might shift to 127 or extended offset. So full extension or no, there should be no FFD, check coverage in all positions, check the impingement. So then you get to the stem, whether you're using a cemented or an uncemented stem, hammer the thing in. A trial reduction is done, long track, give longitudinal traction, flex the hip, guiding head, slight abduction. These are the methods of reduction. Don't lever your cup on your acetabular, whether taking it out or pushing it in. See to it that there is adequate distraction, and then you so it should not be just controlled with the tibia. You should use the assistant, you should use the hook, distract it enough, and then position into reduction position. So assess the orientation of the stem. So final preparation, if you are using cemented, irrigate the canal, plug the canal. You use the cement centralizer, which is a plastic plug, which will keep it in the canal. And then so that cement is not going distally, so that it can be pressurized. So for good pressurization, you should use the plastic centralizer, plastic cement plug. In case of many companies, they provide you a centralizer also, which sort of keeps it in the center of the medullary canal. As I told you, it is very important that the stem remains in the axis of the medullary canal. So hydrogen peroxide sponges to control bleeding if you're using a cemented stem. Polyethylene tube, you can use either a polyethylene tube if you're using CMW1, or if you're using a liquid, the high this setting cement, you don't need a polyethylene tube vent. You just use a cement inserter, which is in the canal as you inject the cement inside. So that is the centralizer as well as the cement plug, so that there is a uniform pressure created in the medullary canal. And as I told you, there is good fit all around in both in the metaphysis as well as the diaphysis. So do be very slow in these steps. Don't rush through them, because if you're too slow, you might end up stem sitting proud, not going inside. If you're too fast, you might see the whole cement splitting out. So try to be sure what you ask your company fellow what is the setting time, so that you are doing every step at the right time. So don't, many people, because of too much worrying, they just insert the cement too early, so it is all liquid. So once they insert the cement, the whole thing spills out. So many people insert it too late, so that it is solidifying already, so stem sits proud. You cannot really position it properly. So don't rush. As I told you, this is the time when you should not talk. Everybody should be silent and focused on the procedure, and they should be helping each other, and everybody should be knowing what is his job in this while this step is being done. So prepare 40 gram cement, prefer low viscosity, avoid outflow before stem insertion. Insert the prosthesis in neutral version. Insert in valgus orientation. That is why I told you you lateralize in the trochanteric area. Hammering is not necessary. Just keep slowly and gently pushing it in. Hammering is done at the last, when I told you quining, when you really tap it into position. Remain immobile in final stages of polymerization. As I told you, everybody should know what is expected of him. You should not be working in different directions. Avoid removing the holders till polymerization occurs. Remove excess cement before setting. So because you don't have to hammer that out later. So be sure what you are doing and what is your role in this whole process. So remove all the bony and cement debris. Copious irrigation of wound, trial reduction with varied neck length for stability. So you, as I told you, if you have measured preoperatively, so you know the horizontal offset, how much it is, how much is the length, how much is the vertical offset, how much is the length. So that you have a fair idea how much length you need. We use even the pin which is there in the supraacetabular area for acetabular reaming. We sometimes keep it there, or at least mark that area, so that we can use that as a measurement tool. So from that pin to once you do a trial reduction, see length of the lesser trochanter from the same pin. That should match your preoperative length. So ensure that your length is achieved as you desire, and test the stability through full range. Again, don't rush here. So see to it that your adduction and flexion is full. It is not obstructed by any post or any pillow there, and try it in different direction, both in extension. Closure is with the same run our technique. What do we do? Drill 4 holes on trochanteric crest. One. So the closure technique is drill the 4 holes in the trochanteric crest. You first take sutures on the rotators. First, you repair the capsule. So the T incision, you should be able to approximate that, as I told you. Once you have dissected the capsule well before you do the neck cut, you'll be able to re-suture it also. So take at least 2 to 3 stitches in the capsule and then reattach the rotators. Do not excise if repair not possible. Don't try to cut. Earlier we had a theory that we should completely excise the capsule, but it's very important that you resuture it. If you're not able to resuture, hello? If you're not able to resuture it, at least leave it there. Don't cut it. Reattach the gluteus maximus tendon, which I forgot to tell you that you should keep a stitch while before you cut that. You should keep an identifying stitch in the gluteus maximus tendon, and later at the end of the surgery you reattach it. You can keep the drains, but many people don't believe in drains. So if there's no active bleeding occurs, you may not keep the drain. There are a lot of papers on whether to keep a drain or not to keep a drain. It depends on your personal choice, but I don't think mostly you don't need a drain, but you might keep it. So watertight closure of the fascia and skin is done. So just a few x-rays. You can see here the old bipolar, as I told you, if there is no good fit proximally, they may end up failing. So you can see here it is a bipolar which has caused a fracture, and then there's loosening. So a long stem is done. So adopter method that is practical and has been proven successful long-term and clinical basis, continuous surveillance of your own results. So don't try techniques. These total hip is a very gratifying surgery, as I told you, but don't try something innovations out of blue. So try to improve your technique slowly and then go to the next level, because otherwise this can be a very devastating surgery, and you can do nothing if your hip is dislocated, or if your there is a fracture of the shaft, or a trochanter or an abductor cut. So these are very devastating results. A few slides about the cementless THA. I think I will rush through this. So as you know, Charnley's low friction arthroplasty, it was fixation with cement, adoption of 22mm head. That is the hallmark of Charnley's, and it has excellent results. Adoption of ultra high molecular weight polyethylene, manual of surgical procedure. So this is the Charnley's low friction, which has stood the test of time, and one of the most successful procedures and landmark procedures. Then slowly the other things started coming. Charnley, Muller type, loosening occurred in 34% of 7.4 years. Nothing stands the test of time as much as a Charnley's low friction orthoplasty. So Muller type, they failed, 40% failed at 10 years. So poor outcome of cemented hips, implant. So all this was dependent on implant design, cement disease. So that is why cementless hips came into reckoning. So outcome poor during 1960s, again because of different devices. So in the evolution, they slowly started failing. So this is a very well-known prosthesis, Moore's prosthesis, which are the holes. So it has a smooth surface, strong adherence to bone, not expected. Press fit with a macro lock window or a fin. Outcomes poor aseptic loosening. So slowly they would start loosening. So that is why more comprehensive understanding of the hip anatomy and biomechanics, advance in surgical techniques, more efficient instrumentation started ushering in, and very good designs, sophisticated designs started pouring in, and then that is why we have reached the present generation of cementless implants. So these are the materials that allow in-bone ingrowth. So with time, they get a stronger hold, unlike the Moore's prosthesis, which with time it lose its hold, it lost its hold. So there was loosening, aseptic loosening. So pore size of porous material is important. So what material the coating is, that is important. So how longevity also depends on that. So bone formation in the pore implant and pore size, increase in connective tissue also, maximum ingrowth occurs with different pore sizes. So all this has led to a cementless. We'll probably have that at a different time. So I'll just rush through this as I'm talking only of this technique. So most current cementless THRs are bone ingrowth or bone on growth type. So titanium fiber mesh or chromium cobalt beads, which you have, or plasma spray stems, which are. So all this has the potential to allow bone ingrowth or non-growth. So that is why they get a good hold. So that is why cementless hips are now very, very commonly done. So implants are fixed to the bone tissue by bone ingrowth, typically in distal fixation type stems. no weight bearing stress on proximal femur, so resorption. So distally they have a smooth surface so that there is distal fixation type stems, but proximally there is bone incorporation, so there is no stress shielding there. So there is stress sharing in the proximal part, so they have longer lasting this. So different stem types, we'll not talk about that. It's a very long lecture. So failure of cementless stems, intraoperative fracture, 5 years stress shielding, 10 years fracture due to stress shielding, osteolysis, and 15 years there is loosening. So problems specific to cementless cups, failure of locking system of polyethylene liner, bone loss in acetabulum, insufficient polyethylene thickness, use of screws, because these areas of screws where it starts loosening. That is why an ideal cementless cup is where you don't have screws. So you should have, because that becomes an area where the lysis starts, so they start loosening it at that level. So failure, other causes of failure of cementless THs, dislodgement of the polyliner 5 years after surgery, osteolysis, liner wear, expansion of the osteolysis via screw hole 10 years after the surgery. So these are the disadvantages of these cementless cups. So same things, disruption of the locking mechanism, osteolysis, loose. So I'll rush through this. Improved. So what size of the head? As I told you, preoperative templating here also it is holds the same this testimony that you should do preoperative templating. Surgical objective is that around 1 to 2 millimeter gap between the cortices and the implant is there. So to get a good hold, understand the difference between the fit and the fill and the optimum fit. So that's why you should have at least a 4 millimeter longer, bigger than the templated size. So you should have a preoperative idea of what template, so that you can go at least 4 millimeters above on that templated size to get a good fit. So this is the same angle of resection is 45 degrees. Relax, the step remains the same. Retractor inclination is again the same. Correct positioning 45 degrees and anteversion 15 to 20 degrees. Screw advantages are that use a strong initial fixation, minute movements prevented, and good bone ingrowth expected if there is no micro motion at the cup. Disadvantages are metal wear debris, because the metal and metal contact between the screw and the cup that starts the wear, metal wear, and then it starts spreading to the inside the bone. Osteolysis of the vestibular side likely to expand due to dispersion of the wear debris. And osteolysis along the screw may occur in case of polyethylene wear. So all these tracks, they allow the wear debris to go along there. Where to put the screws? So there is a safe quadrant. So if you can see on this slide, this is if you draw a line from the greater sciatic foramen roof and around 10 degrees on the so around 30 degrees on the either side, that is where your screws should be positioned. So don't go lower down, because then your sciatic nerve is very close there, or inferiorly also you can penetrate the medial wall. So your screws should be positioned in this quadrant, which is called as the safe quadrant. Proximal cancellous compaction is in uncemented. As I told you, in cemented, you try to go laterally, but there you can fill it with the cement. Here you need to impact. So you use a compactor there. You have a cancellous bone compaction. So rather than curating out the bone to medialize it, lateralize the stem, you impact it with the impactor so that the bone, cancellous bone, is impacted there, so that you have a good bone base there. So ensure that canal preparation, ensure the broaching started posterior laterally. So if you, this is basically if you divide your neck cut into quadrants, so you should remain on the posterior lateral side. Don't go towards anterior side or go towards the, stay on the posterior side of the midline. So if you draw the whole neck cut into the 4 quadrants, so stay on the posterior side so that it is in the direction of the shaft. So broach should run parallel to the posterior cortex to get a good medullary fit. Broaching is, again, as I told you, if it is going while reaming, if the broach is going inside, sinking inside the stem, then you can shift to the next level of reamer. And then finally your HA level stem sinks below the section line, you should use a larger stem. So that is what you should do on trialing. So don't keep a very proud stem. So if your HO coated is visible, that means you have a proud stem. So your neck length may need to be decreased. If it is sinking inside, you either go to the next level of the stem, or you can use an oversized neck, because it's a plus neck. So be sure that you have a good neck length restore. Clues for fixing. So as I told you, trial one, you should try to toggle it, both the stem as well as the reamer, see that it is not rotating there, and then try the you see that range of movement, how much range of movement is got. So to see the stability, instability or stability of the cup, place the hip in 90 degrees of flexion, neutral abduction, and internally rotate until subluxation. If there is less than 60 degrees of internal rotation, determine the cause of the instability. So that is what is also called as combined anteversion of the femur. Okay. So keep angle between the horizontal and the internally rotated operative leg provides an estimation of the combined anteversion of the vesicular component. So combined anteversion is you keep the limbs parallel and then slowly rotate it internally. So at the angle at which the dislocation occurs, it should be up to at least 30 to 40 degrees. So that is an acceptable version. The other technique is runabout, what is called as runabout technique, where you draw lines on parallel to the acetabular rim as well as the head rim. So they should be parallel at 45 degrees of extension, in extension, and 45. I think Dr. Yadav may later confirm that. I have not put that slide here. The runabout technique, concentric lines. So the line on the rim of the acetabular cup and the line on the head, they should be, so head should be concentrically inside the acetabulum in extension, and I think 45 degrees of abduction. I think I'll confirm that with Dr. Yadav. Ensure the appropriate anteversion is there. Avoid routine use of lipped inserts and skirted heads, as these decreased in, so posterior enhanced liners, they sometimes cause impingement. So avoid that. If you should try to get resto good fit with a normal version, so that you don't need extended liners or even the constrained liners. They decrease the range as well as they cause impingement. So repair the posterior capsule and rotators. Work with the patient to ensure appropriate post-operative precautions are followed.
I'm just removing the osteophytes. Just a minute.
This was one
I
video.
don't want to compromise on removal of osteophytes.
So don't remove excessive osteophytes. See to it that they might be providing some stability. Just see to it that they are not impinging on your neck while you are doing extremes of motion. So see it on the table that they are not causing any impingement, because that can lever out your cup. So this is a good X-ray you can see as a class X-ray, where there is a good medialization. You can see the teardrop. The cup is very close to the teardrop. The angle is almost near perfect. The cup is well concentric. The stem is centralized. So you can say a good, well done THR in this case. Okay, so one more example of bilateral. So here you can see no screws have been used. So that means there's a good hip, less chances of wear, less chances of implant debris. So less chances of failure. So good cup inclination, good coverage. They are not neither horizontal nor vertical. So summary, head size should be 32. It has been in most of the audits, it has been seen that you don't need to go to 36. So 32 millimeter head, while 28 head has a good liner thickness, so less chances of wear, but more chances of dislocation. While 32 has less chances of dislocation, but the liner is thin, so more chances of wear. But this is an to see that optimum this you probably ideal thing would be a 32 millimeter head, not a 36. If you use a 36 millimeter head, your liner thickness decreases and there are chances of liner failure in the future. So a 32 millimeter head would be an accepted routine as far as the head size is concerned. So don't go for 36, don't stay with 28. So it has been now proven that the new generation polyethylene is excellent. It can, in fact, it has been found in test conditions. It can last even 200 years. As far as so, if there are no other reasons, liner wear is very rare. So if you're not an cup which is more vertical or it's not properly fitting or any other reason for liner to wear out, there are very the present generation polyethylene is a very excellent material and has a very great longevity. So modular implants are bad because again the neck and the head interface again is because there is metal wear there. So chances of failure at that level, metal wear at that level is again. So that is why Charnley's was considered as an excellent surgery because it was not a modular thing. But now with your more refined techniques like neck length is to be restored, all these things, modular things are still in vogue. So outcome is volume and fixation dependent. So more you do it, better you get at it. And cement is your friend. You should almost always keep cemented implants ready in case you have failed, particularly in older patients. So don't have your ego prevent you from using a cement. It's still an excellent technique, and Charnley's has stood the test of time. So you can still use a Charnley's prosthesis. Thank you very much.